Hello and welcome to this webinar titled Methods of Understanding Mental Health in India, organized by EPW Engage. Before we start, I would just want to mention certain numbers that the WHO has presented to us with regards to the mental health problems in India. So as per WHO report, the burden of mental health problems in India is 2,443 disability adjusted life years per 10,000 population. The age adjusted suicide rate is 21.1 per 100,000. And the economic loss from mental health conditions between 2012 to 2030 is estimated at a little above $1 trillion USD. In the first ever National Mental Health Survey conducted in 2016 by NIMHANS, showed that nearly 15% of Indians above 18 years suffer from mental disorders. The research by NIMHANS presented a grim picture of the mental health discourse in India. However, some scholars have criticized the methodology employed by the National Mental Health Survey. They argue that while the survey claims to have adopted both qualitative and quantitative methods for the study, it is evident that it relies more heavily on quantitative methods. It has also been argued that the survey fails to take into consideration the lived realities of the masses and uses data as a justification for psychiatric intervention. Some scholars have even pointed out that the causes of mental disorders are not just rooted in structural biology, but also in the very socio-economic and political environment of an individual, and have warned against this kind of data determinism. They argue instead for a value-based research and approaching mental health as also an ethical and political problem. On this very note today, we have with us three important speakers who will be bringing in different approaches to understanding mental health. We have with us Dr. Mathew Varghese, who's a retired senior professor of psychiatry at National Institute of Mental Health and Neurosciences, NIMHANS, Bangalore. He was also the principal investigator on the National Mental Health Survey 2016, and currently he is an adjunct professor at St. John's Medical College, Bangalore, and KMC Manipal. We have with us Dr. Sudarshan R Kottai, who is an assistant professor at the Department of Humanities and Social Sciences, IIT Palakkad. He has contributed an important critique of the survey and has been a vocal proponent of approaching mental health through ethical and political problems. And we have with us Dr. Pratiksha Sharma, who is a psychotherapist, musicologist, and is the founder of Brightside Family Counseling Center. Her counseling practice is informed by both her experiential perspectives and recovery research in National Academy of Legal Studies and Research, Hyderabad. Thank you for all of you. Thank you to all of you for joining us in this for this evening. I would like Professor Varghese to please begin with this presentation.
Thank you very much, Divya, and to the other organizers at the EPW for having invited me for this very important discussion and debate about the National Mental Health Survey. And I think this discussion and debate is very important because, as I will mention, we are going to proceed with other parts of the survey in terms of looking at the big cities and the other states where the survey has not been done. So I think this dialogue and this debate is very important because what NIMHANS would like to do is to do a survey that is applicable, useful, and acceptable by most people. No survey anywhere in the world is perfect, and each survey will have its own pluses and minuses, merits and demerits. But in the next 5 minutes or so, I will just describe the earlier mental health survey, that is the National Mental Health Survey 2016 as it's called, just to give the listeners an idea of how the survey was done. I'm sort of thinking that everybody who's listening may not have gone through the details of the surveys, but I'm not going to give you too many details. And I'm not going to use slides so that we can spend more time in talking. So the first, I will tell you a little bit about why the national survey was planned. Till about 2003 or so, there was really no national data on mental health, mental disorder morbidity in India. There were sporadic surveys from different parts of India, and most of the surveys covered what is called as the severe mental disorders. So I will explain what severe mental disorders is. Severe mental disorders is basically what the general public, knows of as craziness or madness. So these disorders are basically the severe disorders, which is basically psychosis. So disorders like schizophrenia or bipolar disorders, these are the severe mental disorders. And there are some organic disorders also which are in that category, which is things like dementia or delirium. So these are the severe mental disorders. There have been sporadic small studies done in different parts of the country about the severe mental disorders. The numbers, the study population was not very large. There were less studies about common mental disorders, and what is referred to as common mental disorders is because the frequency of these disorders is much more. The general frequency of the severe mental disorders is about 1 to 2%, and dementia accounts for about 3%. But the estimates of what is called as common mental disorders by the World Health Organization was upwards of 10%. So most of the time, when you looked at reports from the WHO and other world bodies, as far as India was concerned, they would give a kind of ballpark figure of depression above 10% or depression above 15% and so on, or anxiety about that much. Because the common mental disorders essentially covers depressive disorders, anxiety disorders, stress-related disorders, and substance and alcohol use disorders. These are what is called as common mental disorders. And so the usual figures which were quoted before 2006 or so were upwards of 10 and 15%. So one of the things that the government of India said that which sort of preempted the study was to say that we didn't really have valid estimates of the prevalence or the frequency of disorders in our country. Now, what was the forerunner of this survey was what is called as the World Mental Health Survey. And the World Mental Health Survey has been done in different parts of the world. India was also one of the centers where the World Mental Health Survey was done. And in fact, in about 12 centers in the country with a sample size of about 30,000, the World Mental Health Survey was done in India. This was from about 2003 to 2006. This was carried out mainly by the WHO and mainly anchored by the World Mental Health Survey Consortium group from the United States. Unfortunately, this survey didn't get published for a long time. In fact, it got published only in about 14 or 15. It didn't get published, at least the Indian figures, because the survey was fraught with different kinds of problems. For one thing, it was I mean, the World Health Organization basically quoted only figures from about 5 or 6 of these 12 sites. And that the reason was that they said that the data was unreliable because one of the problems was the survey instrument was very long. The instrument was the paper and pencil version instruments. And so maybe transcribing from the paper pencil onto the computer spreadsheets was a problem. Interviews with each family member took about 3 hours, 1.5 to 3 hours. So there's a lot of sort of burden as far as the survey was concerned. And so this survey was not really successful in that sense. So the government, Ministry of Health, to plan services, to plan programs, especially to help with the national mental health program, just like the the country has various health programs, the tuberculosis program, malaria program, and so on. There is also a national mental health program which has been there from 1982. The national mental health program, right up to about 2010 or so, was rolled out in only about 100 districts of the over 600 districts in the country. It was rolled out only to about 100 districts. And there were many reviews of the national mental health program. And one of the big hurdles was that nobody really knew the numbers. And everybody all over the world kept talking about how common mental disorders are so important. And in India, up to about, even now I would say, we were only dealing with the psychotic disorders or severe mental disorders. The National Mental Health Program really took care of only people who have got severe mental disorders, because basically the doctors, the health workers, and the other people in the health system, they would go out, identify people based on what family members said as people who are having severe mental disorders, and give them treatment in terms of medication, in terms of family counseling and help and so on, and try and diminish disability. And there's a lot of evidence to show that giving treatment diminished the disability and suffering of the people who were suffering from these severe mental disorders. So the National Mental Health Program basically tackled that right up to just about 5-10 years ago. As we didn't have any figures, that's one of the main reasons why this whole survey was planned. So that's about why the fact that we didn't have national level data to plan services, to plan, to budget, to get human resources and so on. That's the reason why the government of India actually wanted to plan this. Now, let me just cover a little bit about what was basically planned in the survey. So the aim of the survey was not just to get the number of people who were suffering with mental disorders, but it was also to look at other things like health-seeking patterns, disability, service utilization, whether people with these disorders actually go and get any kind of help from any doctor or any other sort of professional who will take care of their health. The survey also wanted to look at the level of service and resources that are available in each of these states for mental health care. So there was a mental health systems assessment that was planned in the states that the survey was being done. And finally, the plan was to make recommendations to improve the mental health care and the mental health systems in each of the states where the survey was planned. So the way the survey was designed, the power calculation, that means the outcome that was expected was that we would get figures for the disorders which are about prevalence of about 7%. So basically you would get state level figures for the common mental disorders, which was anyway higher in prevalence. But you wouldn't get state level data for the severe mental disorders, because as I mentioned, the severe mental disorders is only about a 1% prevalence, 1% frequency. And so if you covered a number like 3,000 in each stage, you would really not get very high numbers of people with severe mental disorders. So, but at the same time, if you pooled all the data, national data, you would get prevalence figures for the nation on severe mental disorders, and you would get prevalence figures for the state and the nation on the common mental disorders and substance use disorders. So that is the general aim in which the survey was done. So basically to get prevalence figures, numbers, frequency, and then various kinds of risk factors for these mental health disorders. A little bit about the methodology. The survey aimed to cover adults over the age of 18 years. So 18 years plus on to elder ages. We wanted to do only a pilot survey of adolescents, people from 13 to 17. And the reason was that we weren't really sure how the pilot survey would work, because some of the, and we didn't do children below 13 because it would involve a lot of issues about consent and talking to the parents and not being able to talk separately with the children, and and the instrument was an issue. So we did a pilot survey in only about 4 centers with adolescents. And this is a very small number of about in these 4 centers of about 1,000 odd people, 1,000 odd adolescents. So all adults in 12 states of the country. So the way we chose these 12 states is in some ways very arbitrary, because we just took 2 states from the south, 2 states from the north, 2 states from the east, 2 states from the west, and 2 states from the northeast. And the reason was that, and we tried to cover states with kind of different kind of, say, socioeconomic or socio-demographic patterns. And obviously, since this was the first big survey, we also looked at partners, mental health partners, who would actually carry out the survey and supervise the survey in each of these states. So that's the reason how we chose these 12 states. And even at that point of time, the government actually wanted us to do surveys in all the states in the country. And so the government has actually now asked NIMHANS to do the survey in the remaining 18 odd states, to cover all the 30 odd states in India. Part 2 of this exercise, this is what is called as National Mental Health Survey 1, was also to cover the mega cities, because we knew that the mega cities would be very different. So Mumbai, Delhi, Calcutta, Chennai, Bangalore, and Hyderabad, the 6 mega cities, would be very different. And that is a survey that is actually ongoing now. The survey is just going. We just finished the training of all the field data collectors, and the survey is now going in. It got delayed by more than 2 years because of COVID. So though the instruments and other things were available even 2 years ago, we've now had to do some rethink and add on some COVID components, as to what has happened with COVID and how things have been affected with COVID, and how migration has affected people, and how physical illness has affected people. So we have had to tweak the survey in some ways for the megacity survey, which is now just going out into the field in some of the sites. But the NMHS2, which is the remaining states, will start sometime next year. It's still in the planning stage, and it's something that will start hopefully by next year. But the megacity survey, we hope that will be over in about 6 to 9 months in these 6 megacities. So the sampling all over India for these 12 sites was a randomized sampling. It is multi-stage, and it is stratified, what is called a stratified cluster. That means in every state that we plan to survey, we would choose the areas depending on the poverty indices. So high income, middle income, low income. And then from each, we would in a random fashion choose 3 districts based on this high, middle, and low. And then from those districts, use census enumeration blocks or taluks, which would again select randomly. And then we would go into the households and so on in each census enumeration block. And there's a whole sort of principle that is usually used in epidemiological surveys, where you try and get as random a sample as possible without any much bias. We used mixed methodology. The qualitative aspects was looking at these instruments, but we also used KII, so informant interviews, and also focus groups, but to a smaller population in each of these states, in each of these sites. And also we also did a systems assessment, looking at the state mental health authority and the state government machinery, number of doctors, counselors, traditional healers, healthcare workers that are available in each of these states that we surveyed. So we did a whole bunch of things, whether there was a national mental health program available in that state, whether there were enough psychiatrists, whether there's enough training, whether whether people are following the mental health laws, whether the people are following the disability laws, and so on. So we looked at a whole bunch of things. That is second report is basically about the mental health systems assessment. The first report, which everybody quotes, is really the prevalence data and looking at all the different aspects of prevalence in terms of risk and social demographic aspects of prevalence. And the third report, or rather summary, is the one that came out first. So the summary came out somewhere in October of 2016, and the full report, including the systems report, came out in December of 2016. Before the survey was planned somewhere in 2013. I think the first National Technical Advisory Group meeting occurred in 2013. And all through, we had expert group meetings occurring throughout the survey. We also had a separate national expert group, which is basically an expert group which would advise on the survey. And this NTAG, the National Technical Advisory Group, comprised not just of mental health professionals, but also family members, sociologists, anthropologists, statisticians, and various other people who advised us on the aspects of the survey. So all these details and planning of the survey was constantly monitored and advised by the NTAG and the National Expert Panel. One of the important components of the survey was that we were aware that we're using an instrument called the MINI. This is a MINI International Neuropsychiatric Interview, which is basically an interview that needs to be done, that can be done in the clinic or in the field. But we needed, all of us know that what is considered as a gold standard in psychiatric interviewing and psychiatric diagnosis is basically an interview which lasts about an hour with a family member, with the patient, and all other people to come to a psychiatric diagnosis by a trained mental health professional. And that is usually a psychiatrist, psychologist, or a psychiatric social worker. So that is really what is considered as a gold standard. Just like in gold standard, for a heart disease, it will be something that is seen by a physician or a cardiologist with all the investigations and everything. Now, obviously, when you're surveying about 40,000 people all over India, we don't have the luxury of employing psychiatrists and trained mental health professionals to go out into the field and survey people. And so, all over the world, the way epidemiological surveys are done is by training and making field data collectors adept at collecting data based on structured instruments. We try and see that the instruments are structured in such a way that there is not too much leeway where a person who's doing the interview, the field data collector, there isn't so much of bias that they can just ask whatever the question they want and record whatever they want. So the instruments are created in such a way, and there are many instruments like the MINI. Instruments are created in such a way that there is clear questions that are asked, and then there is an algorithm which is, once you answer yes or no, subject answers yes or no, then you go forward or go out of that category depending on the algorithm that is used. So it's not a perfect method, but this is the method that is used all over the world for mental health surveys or any other surveys for that matter. If you're using non-professional field data collectors who are trained in a large way by the use of the instrument, then this is what is done. So we had a prolonged 8-week training for the field data collectors in all the centers, and we checked on quality by looking at the interviews, looking at reliability data, and having them trained. The field data collectors, as far as possible, were people from the behavioral sciences. So they were either psychology postgraduates or social work postgraduates. We did not have any postgraduates from the non-behavioral sciences field. So we looked for sort of fidelity in the conduct of the interview and looked at the instruments. And the actual survey was done between 2015 October to July 2016, almost a 9-month period. And then we had various consensus meetings with the state authorities, state mental authorities, and other authorities. And as I mentioned, the summary report was published in October, Mental Health Day 2016. and final report in December 2016. I think that kind of covers everything. I don't want to mention too much about the results, but just want to flag something which Divya said. 13% is basically the figures for lifetime prevalence, and that doesn't mean that at this point of time somebody is having a disorder. People having a current disorder was about 10%. And remember, this 10% is broken up into different categories. Many times people say the 10% is all about common mental disorders and depression. It's not really. If you really look at the figures, this 10% actually comprises of severe mental disorders for national figures, which is about it's less than 0.1% current psychosis, about 0.8%. Substance use disorders, including alcohol. Alcohol is a majority, about 4.6% is alcohol. So substance use disorders is about 5%. Depression is about 3.6% or so. Anxiety and stress-related disorders is another 3.5%. So that's a breakup. So if you really look at the breakup for depression and anxiety and other stress-related disorders, it's about 3%. Substance use disorders, including alcohol, about 5%. Severe mental illness and psychosis, about almost 1%. That's a kind of figure. So we did not use the figure. We also looked at tobacco use, which is also a problem because it's a health problem. And that was, if you put in the figures of tobacco, it would have gone up to, because tobacco use itself is about 20%. But we did not use tobacco. We also surveyed, we screened for epilepsy and intellectual disability and autism spectrum disorders. These are only screeners. We did not use them for the actual calculation of the mental health figures. Epilepsy, if you ask me why epilepsy was included, it's because in the National Mental Health Program, all along the history is that epilepsy was also included in the National Mental Health Program because it was a serious disorder which required treatment. There was no separate epilepsy program that was conducted by the neurologists, and now there is a move to see that the neurology colleagues can actually conduct a larger program under the NCD program for strokes, epilepsy, and other kinds of neurological disorders. So now the thing about what we found about disability was that, I think I'm taking too much time, and I'll wind up very quickly. The thing about disability is that the treatment gap and disability was pretty high for these common mental disorders. So people are suffering, people are not getting help, and the treatment gap was upwards of 80 to 90%. But the good part is that for these psychotic disorders, the severe mental disorders, the treatment gap had actually come down. The treatment gap, maybe because the National Mental Health Program was tackling severe mental disorders and psychosis, the treatment gap for severe mental disorders had actually come down to about 70% or so. And in fact, the treatment gap for epilepsy was only about 30%. So the National Mental Health Program was indeed doing something, in the sense that it was at least reducing the treatment gap for psychosis and epilepsy. So that was a sort of gratifying part. But people are suffering in terms of, there were high disability, there were high distress, and people could not get to any kind of help. Well, if they had depression or anxiety or substance use disorders, they really didn't go and visit any kind of health professional for any kind of help. I think I'm going to stop here because I've covered, I think, all the important parts of the survey. I will sort of, I'm for any questions or any other. There are other two panelists who have to make any comments. So sorry for taking almost 30 minutes.
Thank you, Dr. Varghese. I would now request Dr. Kottai to present his points.
Thank you, Divya, for inviting me, and very good evening from Palakkad. As the topic of discussion for today's methods of understanding mental health, I think it is important to not only think of methods of doing research or survey in mental health, but also alert ourselves to the everyday practices that produce the popular knowledge or discourse in mental health. So I would like to refer it to as the space attitude administrative complex that creates the imagination of what it means to be mentally ill or mentally healthy, and what mental health professionals like psychiatrists or clinical psychologists or the mental health system should do or are supposed to do. For example, if we pay attention to the websites of state-run mental health institutions, which are largely public interfaces now, because it's it's a digital age, so most people will like to browse and understand what institutions are doing, like NIMHANS is doing, what is National Mental Health Survey, all this. So there is a dearth of information or resources that enable us to imagine mental health problems and the solutions from multiple perspectives, as many scholars have been pointing out that there is no single correct way of being or doing mental health interventions. So rather than thinking of psychology or psychiatry as single discipline, many psychiatrists, psychologists have been talking about psychologies and psychiatries with different epistemological positions and methods of inquiry. But what we see in the popular discourse, or how it is produced by the institutions mostly, is that of the dominant medical model of understanding mind or mental health, mental illness, etc. So we don't find any reference to issues like casteism, sexism, or heterosexism, cisgenderism, or state violence as a major determinant of mental health in the Indian context, and the need to target those upstream factors in the mainstream mental health discourses. So as these understandings mostly flow from the Western biomedical understanding of mental health and the social, cultural issues that we face in the global South, and particularly India being a very poor country and having a lot of social issues. So instead, the biomedical ways of knowing are overstated with an obsession with data on diagnostic categories and the need to seek treatment when most mental health problems have a socio-political origin, warranting transformative social change. So it really applies to the common mental disorders, and also now scholars have been talking about the need to understand severe mental disorders also from a very integrative point of view. It's not about completely avoiding the biological or the other existing paradigm, but about integrating and to also accepting, accommodating other voices rather than having a dominant paradigm which has been existing for a longer period of time. So the focus remains on symptom reduction, which may not be a priority for the user of the mental health services. So the homegrown first-person perspectives based on lived experiences on tackling mental health problems are sidelined, thereby reinforcing the biomedical dominance when research is accumulating regarding alternative paradigms that are effective, sustainable, and ecologically valid. I think the panelist, Dr. Diksha Sharma, will have a lot of things to talk on that. When official discourses of state mental health institutions paint a grim picture of mental health, like the National Mental Health Survey that 11% of Indians suffer from mental disorders, there is little attention being paid to the upstream factors or the causes of the causes, and also on people who face barriers in realizing basic fundamental rights, human rights, and constitution on a day-to-day basis. So these marginalizations and layers of exclusion becomes a political, historical, and ethical issue revolving around power imbalance. But mental health discourses often continue to remain largely apolitical, value neutral, and historical, foregrounding mental health problems as a medical problem when the mental health problems are often markers of compromised social structural conditions, historical discrimination, and social injustice. So we see certain disorders are prevalent more in certain communities, certain culture have, in certain culture there is more prevalence of certain issues. So it has a lot to do with where people learn, how their situation or how their living shapes their being. An aspiration to be objective and scientific in side disciplines discounts the richness of other methods of producing knowledge in mental health. For example, now we have been talking about community-led, user-led, participatory research that produces novel solutions, which may be very different from what we imagine in the popular discourse as the problem and what needs to be the solution. So I came across research in Brazil by a psychologist where cash transfer schemes have been found to be very effective in reducing the rate of suicide. There are also findings that countries with anti-LGBTQIA discrimination laws and other protective measures have lower rates of suicide in the community. So taking an example with respect to LGBTQIA plus rights issues in India, since the Nalsar judgment in 2014, the judiciary has been invoking constitutional morality to uphold human rights. Verdicts of the Supreme Court and High Courts, including the landmark judgment of Navadeh Singh Johar in 2018, that decriminalized same-sex relationships, have been instrumental in initiating transformative social structural change. The ban on conversion therapy and the directive to remove derogatory contents against LGBTQ community from medical textbooks by the High Courts of Kerala and Tamil Nadu are recent examples. In contrast, the mainstream mental health systems failed to act in voicing human rights and protecting the marginalized community, except few position statements from the professional associations. Even though the Supreme Court directed the mental health fraternity to exercise utmost sensitivity to LGBT issues in 2018, there is an absence of gender affirmative guidelines and failure to suggest punitive actions against the medical fraternity or the psychology mental health fraternity who support and practice conversion therapies, which point to the diffidence and silence of Indian mental health systems. So recently, the National Medical Council had brought a directive, but it was based on the directive of the Madras High Court. The focus of the profession has to be on the reversal of prejudice if it seeks transformative change and not on the reversal of the sexual orientation. In a paper that I co-authored with Professor Rajalakshmi from Public Health Foundation of India, which is accepted for publication in Indian Journal of Medical Ethics, we argued that tendering an apology by mental health systems, given their long-standing history of routinely contributing to the oppression of non-heteronormative people, is vital to de-escalate this ethical crisis. This is also a problem. Why I talk about this is that there's also a problem with methods where quantitative metrics dominate the mental health research, and where most of the research measures prevalence of depression, anxiety, etc. in marginalized people, including LGBT people, and seeks more individualized interventions to solve the problem, because the outcome of the research is that they are more vulnerable to mental health issues and they need mental health interventions. So it's important to note that not also the non-representation of the research community in decision-making about research. The research priority is set by the mental health professionals, and the outcome is a lack of co-production of knowledge, which erases stories and problems of living, replacing them with numbers. So the denial of social justice stemming from exclusionary attitudes and policies cultivate conditions of unlivability, mental distress, or substance use or death by suicide. So we don't have enough research or voices from mainstream mental health that integrate these painful experiences with mental health problems or integrate various views to produce an ecologically valid understanding of mental health. So it's also important to note that in 2021, the American Psychiatric Association and American Psychological Association tendered a public apology for instituting racism in psychology and psychiatry disciplines. So I think this is a stark reminder that psych disciplines are not immune to socio-political climate and other influences and bias. So why have they concurrently failed to appreciate the structural materiality of marginalized people's lives that perpetually impact mental health? One of the main reasons can be attributed to the dominance of the quantitative methodology, which is overstated in mental health research, and other methodologies, like qualitative methodology, which are underrepresented and understated in in the mainstream mental health training and research. That's all from my side. Thank you.
Thank you, Dr. Kottai. Thank you so much. I would now request Dr. Pratiksha Sharma to give her presentation. Ma'am, you're on mute.
Thank you, Divya, and thank you for the opportunity to you and to EPW. And I think I would like to share with you and the other panelists as well as the audience here that the perspective that I'm here to speak about is the lived experience of mental health issues. And Professor Varghese just talked about severe mental illness. So I'm one such person who has lived through bipolar disorder. I was treated for 18 years and I recovered for the last 12 years. And I did a PhD. I specialized in recovery, understanding recovery and the contours of recovery and why more people don't recover. So I bring in that perspective to this discussion. And I would like to go a little back, and I'd like to say that this webinar is based on the idea that there is a reality of mental illness which is identifiable, which can be isolated and treated. And psychiatrists and allied professions are the best people for the job. And once the treatment starts, the person starts recovering. And then that treatment is usually expected to last for the rest of someone's life. So in other words, psychiatry assigns itself the job of identifying mental health issues, however they do it, these surveys and all that. And then say that we not only have the capacity for identifying, but we also have the capacity to treat them and deal with them and let people like whatever. So my question to such practice of identifying would be, what is the goal of your identification when your treatment is not producing a cure, but disabling people instead? And this is my finding from my research, that once a person enters the mental health system, there is not much possibility left for them to exit the system. So they are on medication for the rest of their life. I am not on medication from the year 2010, so which is over 12 years now. And I exited the system. And in my PhD, my finding was that people exit the mental health system, and there is recovery happening both in schizophrenia and bipolar disorder right in India. And people are recovering beyond the psychiatric gaze. They don't go and report back to their psychiatrist that, look, we have recovered. So the thing is, all these surveys that we are doing, all these normative practices, we decide that these are the norms, these are the questions we're going to figure out. We're going to find out how many people we have mentally ill, but what will you do with them? You will just bring them into the mental health system. And by the way, one of my key findings was that once a person enters into the mental health system, thanks to the mental health law as it currently prevails, there is nobody who can exit the mental health system. Anyway, I'll just say what I have to say before I get to that point. So what does psychiatry gain by saying, when we say that psychiatry stakes the claim that we have the means and the tools to identify mental illness and then we can treat it? What is it gaining? So it is saying it is actually shaping public opinion by making people believe that their problems of living are actual medical conditions which are treatable. Psychiatry is funneling people into the mental health system, and it is driving the sales and profits for pharma products. It is not solving actual problems. It is only ensuring drug compliances, and it is turning the patient into a psychiatric subject. Some of you may have heard the idea of psychiatry being a colonial force. And I'm going to come to that. And then the last point I have to say is, it is governing the individual via the family. So the family will say, they'll tell the family that, look, you have to make sure that the person, your loved one, is not going to take any treatment. They're going to say no to medication, but this is a serious illness. You have to ensure that they remain compliant, and they are basically instruments of control of people. And this is what psychiatry ends up perpetuating. People think that they have a real illness. Whether they have it or not, nobody has established that. Nobody has done any test or anything. They have just looked at people's external behaviors and based on that, determined that they have a real illness inside their body, which they call as a chemical imbalance. Which the chemical imbalance is a theory which psychiatry has propagated, by the way. And I have a lot of problems with that theory. So I'm saying I reject this whole idea completely. And I'm saying that I have an ontological difference. I look at people's mental health, so-called mental health issues very differently. I think it is a problem of living. It is not a real biological illness, a chemical deficit inside a person. It's a circumstance. It's a circumstantial suffering. It is because of their circumstance that the suffering is happening. You change the circumstance, the suffering is mitigated. And that's why when Sudarshan just said, if you're giving people money in Brazil, if you're giving those cash transfers, it helps, because it takes away the anxiety of what will I eat, how will I pay my bills or anything. It just gives a sense of power and control to people. So what are we doing to help people's distress? The reality is, can people change their distress-producing circumstances? More often than not, they cannot. They cannot change their circumstances. So since they cannot, let's medicate them. And that's what psychiatry is doing. What if I were to tell you that there is no real illness in a person? Why am I saying that? Because it cannot be isolated by tests and measures, except subjective scales developed by psych professionals. There is no pathological test which can establish the so-called chemical imbalance in anyone at the start of their treatment. Day-to-day problems of people's lives become medical issues as we are increasingly medicalizing life. Mental illness, that's my position, is a psychiatric construction. There is no illness, there is a deep suffering, it's a distress. And when people start taking medication, that is where the distress is consolidated. It becomes pakka. There is no way that people are able to exit that treatment, because now they believe I am ill, I have to be treated, and they stop doing everything else, start looking at the treatment, the doctor as the person who has all the solutions and the answers for their problems. So the thing is that we have to look at, and I have all due respect for Professor Varghese's work. There is no problem with what he has done. I am only going to say that the whole paradigm itself is erroneous. It is not, and even if we construct all these tests and all these measures, what do we gain from that? If we start medicating people, where do we go from there? We are just disabling them. I have seen that innumerably. I work in psychotherapy with peers. I'm a peer therapist. And I have seen that I'm able to support people exit psychiatry, but I've never come across one psychiatrist in this country who says, you can stop your medication. People don't do that. They say, no, you have an illness, it is biologically embedded, it is really there, and you have to take this for the rest of your life. So the problem is that there is no problem as such. It is a problem of their life, whether they got low marks in their class, whether their marriage failed, or they were kicked out of the job, or something else happened, or some death or bereavement in the family, or anything which is distressing in their life, or a childhood trauma, sexual abuse, you name it, kind of thing. These are problems of living people face, and they are traumatized from those problems. And those problems make them panicky, worried, afraid, fearful. So fear is the basis of everything that happens in a person's life. It distorts their behavior. When that behavior is distorted, and that behavior is interpreted by somebody else as pathology, as illness, that is where they come under the remit of psychiatry. So the whole notion is problematic. And as long as people are going to come into these surveys, I mean, I'm not saying let people come into the surveys, the government has funds, it wants to spend that money on surveys, well and good. But let's be clear that these surveys are not going to do anything except normatively define certain things. It is good for the government because they want to do that work. They want to show to the World Health Association Assembly that we have done this thing. They are answerable to them, but what about the people? What about the people who are being disabled by being on antipsychotics for 10 years, 20 years, 30 years? I've seen people like that. And they are so wedded to their idea of that they are mentally ill now, that they are disabled because of the medication primarily. I have been there. I have been on antipsychotic or some medication, antipsychotic, antidepressant, and those mood stabilizers. For 18 straight years, I've been medicated from the age of 20 to 38. So I know what that zombie state is. And I know that psychiatry disables. It's not the disability which is produced. That disability is still something which passes. It can pass in 6 months, it can pass in a year, 2 years. But psychiatry will actually progressively disable you. It produces iatrogenic injuries. I've of course written about that in my in a book that is forthcoming. How people, when they are on prolonged psychiatric drugs, antipsychotics, all kinds of drugs, they have all kinds of injuries, health, sort of comorbid conditions coming out of that. So it's not the disability is because of what they are experiencing only. This is the double violence of psychiatry. So I think Sudarshan has very meaningfully pointed out that all the fact that problems are sort of embedded in people's socio-historical situation and circumstances. We have to look at that. We cannot say that, okay, we need to do the survey and then what do we do after that? What do you want to do after that? If you are saying that you are treating people, what is the goal of your treatment? I think psychiatrists need to introspect on what they want to do with these treatments now. Because it's very nice to have all these surveys in place and you can say, okay, 15% people need treatment for what? You change their life circumstances, everything changes, but you can't do that. So you start treating them. I mean, I think we need more justice in society. We need more concern for people as human beings and not just as subjects of governance. Once you bring people into the pool as they don't have bread, they don't have enough nutrition, they don't have housing, they don't have safety, they can be killed because they're a Muslim or they're a caste-based problem or on anything. And then we have a situation where psychiatry intervenes and says, no, this person needs this treatment, this is not the way we are going to produce social justice in society. We have to see what are the goals of psychiatry. I'm not going to tell psychiatrists what their goals should be. They have to self-introspect. But are they really producing a society with all these normative practices of looking at percentages of people, of telling people that you need to do this and that? I mean, we have so much of depression. Why do people have depression? I have worked with so many people who have recovered from their depression, including bipolar depression. I've seen schizophrenic depressions. I've seen voices I've heard. I mean, not heard personally, but I'm saying I've worked with people and our voices stop when you start understanding what the basis of those voices are. When you start addressing, anyway, I'm a peer, I look at things very differently because I've been there. I have integrated my own experience at a very serious level also. I am ontologically not looking at mental illness as a real illness, but as a suffering, as a distress, which gets congealed as illness because it is called so. And why is it called so? Why is it that psychiatry calls, okay, that is their problem, then keep calling, but why is it accepted in society? That is the moot question. Why is psychiatric knowledge accepted in society? Because psychiatry has epistemic power in society. It is socially acceptable. It is a discipline of medicine. And they have a social consensus that, yeah, what they are speaking is the truth. It is real knowledge. It is science. The science which is about controlling people and not solving their problem really. Because you can't solve the problem. Because you can't solve the problem, you start treating the person. The problem is more systemic. It is more in the social situation of that person's life. And we have to see, I mean, really psychiatric professionals have to think. But anyway, this is not the scope of this dialogue. This discussion is something different. My question to anybody here is not to ask for answers, but for everyone to think that what purpose are these surveys serving? And who are they serving if not pharmaceutical corporations? Are people's problems getting solved by these surveys that we are having? And if when we say that we 15% people in this country need medication, what happens after that? We have pharmaceutical industry which is interested that, oh, wow, 15% out of every 100 people in India, 15 people are going to have medication now. That's great for their profits. So you have to now create that frenzy. Let's talk about mental health. Everyone's talking about mental health because you are creating that acceptability about mental health issues. You're not looking at issues which are of people's day-to-day living. And since you can't solve those issues, this is such a world where everything is determined by the market. So this is it. Anyway, so I'm not going to take more time here because I think I can't, this is not the scope, there is not enough time, but I had to bring this up that There is nothing like an illness for life. There is, I don't believe that mental illness needs to last. It's like a fever. If you can give an antipyretic, if you can respond to a person's distress in a proper way, and you de-escalate their problem, it will be solved. I have solved my own problems. And of course, there is a whole lot of writing I've done about myself. It's all there in the public domain. You can read. But I'm saying that, and that problem is solved for not just me, but many people. So even my book is going to talk about more people who have recovered, why people recover, why they don't recover. So what are the barriers to recovery from psychosis? That's the title of my book, which is forthcoming. So I'm saying that you have to understand that no illness is for life, especially mental illness. And when psychiatrists say it's for life, they don't know what they're talking about, because they are not tied to recovery. They are tied to maintaining the patient as patient. And I stop here. And we just have to question these practices. 15 minutes are up. Being a musician, I tend to look at time very closely, because that's how you accommodate everything. So Divya, over to you. Thank you.
Thank you, Dr. Pratiksha. Dr. Varghese, I'm really curious to hear your viewpoints against the strong position, on this strong position, actually. Would you want to respond?
Yeah, so I think, I don't want to have a debate about whether mental disorders exist or not, because I think that's not the purpose of today's debate, whether mental disorders exist or not. I think you need to ask the persons who suffer with depression or anxiety whether they want any kind of help. And that's for people who suffer from depression or anxiety. And you need to ask families of people who have severe mental disorders like psychosis, because in a psychotic state, many times the person who's having the illness may not know that they have an illness, but the effect of the illness is felt by the family, in the sense that whether there's paranoia, or whether there's hallucinations or hearing voices, or the person is inactive, or person is starving to death, or whether the person is running up money, those are things that the family has to face. So I don't think that debate is what we are at. Doing a mental health survey is not equal to treatment. And what I think Sudarshan and Pratiksha pointed out is about a person's lived experience, which is very important, and a person's own suffering and what needs to happen, which is very important. But that is not the survey. Survey is basically to look at factors from a national perspective, which are important for programs and for the country per se to deal with the problem of mental disorders. Because if we didn't do any surveys, and if we said that, okay, let's only talk about people's lived experiences, the government wouldn't come into the picture, and there wouldn't be any forget psychiatrists, they wouldn't even be doctors if we didn't do surveys. There would be doctors even to tackle hypertension or diabetes or any of the physical illnesses that people suffer from. So obviously, with humanity, we all know that some kind of healers are necessary. Whether you call them traditional healers or other kinds of healers, some kind of healers are necessary, because that is a profession where people are reaching out to seek help. Now, the debate that so what I want to say is that the mental health survey will not tell you about the treatment of psychiatry. It will not cast any kind of information on the treatment of psychiatry. If you want to see how particular disorders are treated, whether it's bipolar disorder, schizophrenia, or anxiety or depressive disorders, there are different kinds of studies which look specifically at the disorders and see what treatments are effective, what treatments are not effective. And we are in this age where we're looking at evidence-based medicine, and the whole world is doing controlled trials which take out the bias of people who believe or don't believe in the disorder, and they're actually looking at whether X treatment or Y treatment is useful or not for the person. So we are in the age of evidence-based medicine, where things are very clearly thought out as to what is the treatment of various disorders. So the survey will not tell us about that. Survey will only look at large-scale national numbers and look at risk factors. So as Sudarshan pointed out, indeed, it is very important to look at life events. It's very important to look at socio-cultural issues, because we all know from research over the years that mental illness and disorders and distress is definitely higher among the people who are marginalized, people who are in war situations, people who are facing poverty, people who are facing different kinds of stressors in their lives. Indeed, suffering and mental disorders are much higher. And we also need to distinguish between what is the mental illness and what is just mental suffering. So, for example, if if you're facing bereavement, if somebody dies, say your father or your mother or your husband or wife dies, you face bereavement and you go through depression, that is not a mental disorder. That is a normal human experience. But when the depression or the anxiety is continuous, lasts for many weeks and months, and it causes the person to not work, not carry on daily activities, or it causes a lot of distress for the family members, that is when it's called a disorder. It's not anything that people suffer as a result of their marginalized situation is not a mental disorder. So that is what. So the word depression, anxiety is in some ways not clinical depression and anxiety. Depression and anxiety is something that we all refer to as saying that I was depressed because I did this or I did that, or I lost money, or I didn't pass an exam, or what. You can be depressed or anxious. That is not mental disorder. And I think now it's very clear that mental health professionals don't label everything as mental disorder. But it's true that mental disorder and mental illness has been used across the board, not so much now, but in the past, to label people. For example, political dissidents, or say at one stage homosexuality. When I started off my clinical training, homosexuality was a category, but now it's not. So it has been used to sort of stigmatize people. For example, premenstrual syndrome was a category, and it went out of the classification system because women felt that they were being marginalized because you're saying that they were mentally ill because they had a premenstrual depression or premenstrual syndrome. So many of the things that both of you said is true, and the debate is not about whether mental illness exists or not. The debate is about, and the debate is not today about how we should treat mental illness, but to what Dr. Sudarshan said, if you look just at the lived experience, or if you just look only at the personal experience, that can only tell you about how you should deal or handle or treat or help somebody who's suffering. But it will not tell you about the national numbers and the national the magnitude of the problem. It will not tell you that. In all medical, of course, there is always a debate that there is a medicalization of mental disorders. Now, in all of medicine, psychiatry claims to be part of medicine, but the mental disorders are the only disorders. The mental health practice is the only practice where you use what is called as a bio-socio-cultural model. So more than anything else, in psychiatry, you look at the psychological aspects, the social cultural aspects, you look at the environment, you look at the community, you look at everything. So a good mental health professional will actually not look at only the disorder, but will also look at how the disorder is affecting or impacting the person's psyche, the person's family, the person's community, and how this whole system is interacting in a positive or negative fashion with the individual who's suffering. So though we use a so-called medical model, it is not really a pure medical model. It is a biopsychosocial model when we use in the treatment of disorders. So that's my sort of quick treatment. What Pratiksha said about, again, it's a debate that, of course, we are all aware of the debate that it's a kind of hegemony by the pharma companies. That's true to some extent, because pharma companies have a lot to gain. and the pharma companies, are influential in the sense that they have been known in the past to influence the psychiatric fraternity to include certain disorders purely for their gain. That is true, but people are becoming more and more aware, and that is happening less now. And with many disorders, with many chronic disorders, sometimes you say treatment is indefinite, but many times it's not a lifetime. Even with diabetes and hypertension, where you tell people the treatment is indefinite and you might have to take it forever, as you grow older, you don't need to take, you may not need to take on medical advice treatment for hypertension and diabetes. Similarly, for mental disorders also, each mental disorder is very different. As you go on through time, some mental disorders don't require treatment for life. Some mental disorders might require treatment for life. It's about a third of people who continue to have a chronic disorder and have treatment for life. And it's a third of the people who might have just 1 or 2 episodes and remain totally well, as Pratiksha has said after that. But there is a sort of 60% of people who have some disorder who may not recover fully, but every time they might need to be on medicines to maintain good functioning. And that is something that they themselves learn out of kind of trial and method. Most people in India stop medication. Most people are not compliant. And so I would say only about 30% of our patients, or even less, are really compliant on medications that we give. And that is true even for the physical illnesses. Even for hypertension and diabetes, people are not compliant on treatment. So they learn with experience, they learn whether they should have medicines or not. So if somebody's diabetes goes out of hand, hypertension goes out of hand, or psychosis goes out of hand, then they know they have to be back on treatment and back on medicine. So we don't really sort of pronounce a judgment and say, okay, take treatment for life. So that is, I think, a false notion that people have, that doctors will always advise that treatment should go on for life. And then, we are all in a nexus with pharma companies because we want to sell, antidepressants and antihypertensives and cholesterol medicines and everything. I think that's just a sort of, it's
a notion. Dr. Varghese, you may be a very kind soul, but I also have a 30-year footprint in this field now. I interact with people from all across the country, in fact, all across the world also now. I interact with all kinds of people in my peer capacity. I listen to all, and it's my deliberation that I don't call the word illness, but I use the word distress, because I see it as distress. I see it as distress which is prolonged, which of course you're right, which you would like to classify as illness, because that's how you relate with this. And I don't say that family is not troubled with whatever the person experiences and then they have to intervene. So in India, family is the dominant mode of support, form of support everybody has. So that of course is going to is the first line of action for anybody. However, I think, and of course, you being at a government institution, you may not have troubled people so much about prolonging their medical treatments. But I have not come across, apart from government hospitals, any private psychiatrist who tells a patient that you can stop your medication. It never happens. And even for the smallest thing, they'll say, no, you please stay on a small maintenance dose. It will be good for you. And people stay there because out of just that sense of fear that I want to be safe for myself. And that's how it is. And it's very nice to read the bio-psychosocial approach. But actually, if you go and see in any hospital, whether private or maybe private is slightly different, but in a government hospital, if you go and see the kind of cues doctors are responding to, there is no scope to accommodate any bio-psychosocial perspective, listen to a patient and know their context, where they're coming from, what is their life story or any of that. So it is all very nice to say that in research, because we are all researchers, we all understand that very well. But the reality on the ground is completely different. Theory is different. And the other thing which came to my mind was that, sorry, I think I just forget what I want to say. Okay. Pratiksha ma'am, what is your opinion on therapeutic communities, democratization of the whole system? I think okay, what do you mean by therapeutic communities? You mean to have an epistemic plurality? I mean, more modes of treatment or support to people. Somebody wants to take the Ayurveda path, somebody wants to take the homeopathy path, somebody wants to go the faith healing. I think if that is what you have in mind, Akhila, I think democratization is of course necessary, both from the intervention, from the therapeutic perspective, as well as from the patient's choice perspective. Currently, the mental health law which is in place is actually taking away all the pluralism that we had, the medical pluralism, the choices people had. This is just replacing the medical model, overarching above everything else. And I've written in detail how a homeopathic system institution also is coming under the sort of gaze of psychiatry, mainstream psychiatry, as though the homeopaths are accountable to psychiatrists. So all that plurality which we had in the system is being done away with. And there is a lot of, I find a lot of demonization of alternative systems. So if a person goes to a psychiatrist and says, look, I want to try something like Ayurveda, homeopathy, they'll say, okay, it is your problem. You want to do it, please do it. But don't ask me whether it is going to have any results or not. So that fear or that doubt which the psychiatrist will put in the mind of the patient is going to let them, they will not want to take that path at all. They will just be worried about that when the doctor doesn't permit. So I think, Dr. Varghese, I mean, I think this debate is not about what we're talking about, but it's about the necessity of doing that survey which you have done. And I absolutely understand where you're coming from and the need for the government to quantify for its own purposes. I'm talking of the qualitative perspective, you're talking of the quantitative perspective, and they they have their own locations, they have their own tasks. Because I'm looking at the human being one-on-one, and you are looking at the big numbers where the funds have to go in and the infrastructure has to be developed. And that is because this whole notion of treatment gap, that we have such few psychiatrists and psych professionals in the country, and the population is so huge, and we need so many more professionals. So we need that many more doctors, we need that many more hospital beds, we need those massive structures of governance. That's what this data is all going to be. I mean, that's the purpose this data is going to be, because it's going to serve certain monetary purposes. Government will assign certain funds for this thing. And that's why your data becomes legitimate or meaningful from that perspective. Whereas what I'm saying is from the person's perspective. You know, every individual that I sort of interact with, I hear their story. I understand that qualitative perspective very well. And that's why what I say also has a different kind of meaning. It cannot be so easily dismissed that, okay, well, this is distress or something. I understand perfectly what psychosis is. I understand very well the whole spectrum of all kinds of things. I will not say anything further.
Can I?
Divya, I
Can
think
I
if you're
request-
moderating the discussion, there are a lot of questions in the chat.
Yeah,
So I
there are
don't
a
know
lot
if
of
you want to look at
questions. But before that, does Dr. Kottai want to say or add anything to the discussion? I would request Dr. Kottai to.
Thank you, Dr. Mathew and Dr. Diksha, for the insights. So I would like to add on the bio-socio-cultural model that we all talk about. I was also trained as a clinical psychologist at a central government funded institution, but it appears, as many scholars are also talking about, it looks like a bio model. The psychologists also follow the typical psychiatry textbook, the social worker almost always. It's not like they're all psychiatrists or all mental health professionals do that, but majority, because I was also trained to be like, even when I was in the OPD of an institution in Assam, when I was being trained, I used to see people who come with long beard and full burqa. I was from Kerala, so I was very curious to know about them and to talk to them and understand. But my supervisors used to interrupt me and say that your task is to diagnose in 60 minutes and give the diagnosis. You are not supposed to hear their stories and understand. So, also because we know that psychiatry is very different, and psychiatry as a medical discipline has to have that co-presence to understand the alterity differences, culture. It's very complex. It's a very complex exercise. So in such a complex exercise, we talk about biopsychosocial model, but in practice, for example, the National Mental Health Survey itself or the mental health itself comes under the larger rubric of medicine, under the Ministry of Health and Family Welfare. We have no intersectional very less kind of intersectional, interministerial understandings, because still mental health is governed at the health level. But as Dr. Pradiksha has been talking about the need to imagine mental health differently at a wider level, bringing up perspectives of users, bringing up from a developmental perspective from very many socio-political perspectives. These are, although it is said that it is there in the textbook, even in the training, it is seen as a footnote. And also we can see even even though we talk about even psychiatry, psychology, and social work and nursing as these four departments constitute the main departments in any mental health institutions. But the dominance is always by the biomedical or the psychiatric. We never had a director of any mental health institution from other than psychiatry. It's no clinical side, because we talk about teamwork and all, but it happens mostly. I'm not saying that. I have also seen in my training that few psychiatrists who I can count on my fingers, who used to hear and used to actually give due respect to the clinical psychology or the social work profession, take their perspectives into account and have a dialogue. It mostly happens to be a monologue. So I think that has to change, and I think people who are more accommodative, or those who have been trained in multiple perspectives, and now I see differences in people. Even when I was trained in mental health, I never had understanding beyond ICD-10 or DSM-5. But when I went to a PhD program where there were departments like medical anthropology, and I was in the class, and the medical anthropology teacher who was there, she asked me, you are a clinical psychologist, you might know Foucault. I was not able to even pronounce the name because I never heard about a scholar like Michel Foucault, who has written a lot on mental health, because this was never being foregrounded. It was never foregrounded in the mental health trainings. So I think the kind of impact also, I think, because National Mental Health Survey, even though we say that it is not about diagnosis or not about identification or not about the interventions, most of the researchers articles that we read, even the President of India in a speech said in a program that we have a National Mental Health Survey which shows that the prevalence rate is 11%, and we need to scale up mental health services. So this is the impact, and there is no caveat or there is no disclaimer being given by the mainstream or state-sponsored mental health professionals or systems that this National Mental Health Survey is a pilot survey, or it has many demerits, or it is not about the interventions. But this is accepted widely as first National Mental Health Survey which has shown this much of prevalence. And what is the response? It has to be the scaling up of services. But what kind of services needs to be scaled in a country like India, where immense poverty, immense inequality, like policies which impact people very badly, state-sponsored policies sometimes impact people very badly, like migrant workers crisis, which happened during COVID-19, was something which was very grave, and it was a human rights crisis that India witnessed on a larger scale after the partition. Many scholars have pointed out. So I think the need to imagine mental health beyond this health and psychiatric perspectives, and to take it away from the health department and take it, I'm not saying that take it away completely, but to integrate with other department. Also, when we talk about these things like team building, and even when there is no sort of interactions or accommodation within mental health professionals, non-medical professionals, and other social professionals, social science professionals who come in mental health settings, then we may well imagine how this might translate into collaborating with people from social occasions like that of Dr. Pradiksha, who comes from a very different perspective, but which is very important. Thank you.
So shall we take the questions from the audiences? I think One question that is being asked is, why is mental illness a stigma in society when the treatment givers are doctors? Is the Department of Psychiatry making any efforts to get rid of the stigma in society?
Okay, can I respond to this? Because I've done this right in my writing also, I've responded to this question. So the government has spent a good amount of money on this whole thing of stigma reduction. And what they've done is, in fact, instead of, so my whole approach is patient oriented. It is not to medicate the individual. I'm looking at how does the patient benefit from any policy, any intervention which the government is making, any doctor is making. So I look at the recovery orientation, basically how can people recover from mental health issues. And what I found was that when the government is spending money to sort of to popularize mental health issues, they are actually telling people that it is okay to take medication, and they are spreading the uptake of psychiatric medication. That is what the finding was. So whereas one would have thought that the stigma against people, the prejudice that people have against the so-called mentally ill people will be reduced, and they will be more accepted in society, they will be less feared, they will be able to intermingle more with people, but that is not happening. And instead the whole campaigns are now to create more acceptability for psychiatric medications. It's okay to go to the psychiatrist, it's okay to go for a therapy thing. And that is the kind of thing. More actors and film actors and all kinds of celebrities are talking about mental health. Let's talk about mental health. I think you may have heard that refrain also, because mental health issues are now being normalized in society. It is okay to have a mental health issue. It is not so. When you say when stigma, to get rid of stigma, you have to get rid of people's ignorance, and that ignorance is based on prejudice. It's a historical prejudice that the mentally ill are to be feared. They have a problem, their families have a problem. We will not marry a son or a daughter into that family. There's a mentally ill person over there. It's a historical prejudice. And if you look back at the 1912 Act also, Indian Lunacy Act, it was all about perpetuating this idea that the lunatics have to be worried about. You have to put them, isolate them, whatever it is. So this is a historical prejudice that is continuing through time, which is still continuing. Even the present Mental Health Care Act has actually taken that 1912 Act as its foundational pillar. And it has said that mental health issues are a real medical illness problem. Whereas this is where I differ from the whole position, that it is not a real mental illness which you can identify with a test or a measure like a blood pressure or some kind of a blood pathological test or anything, nothing. It is just a behavioral problem on the surface of it. The person is experiencing fear or some kind of anxiety. It's a fear. It's everything is based on fear somewhere. That fear may have happened very recently in the past, or it may have come from 10 years back. It is all some fear, some trauma which has troubled the person. So when people are ignorant about something, whether it is about a mental illness, it is about some other person, like the other, it can be somebody who's so-called Muslim, Hindu, Sikh, or Kashmiri, or you name it, kind of a thing. When you have a prejudice about the other, that is where you stigmatize them. You may have heard of Kashmiri boys being in a hostel and they're being hit because there was a cricket match between Pakistan and India, and they sort of supported the Pakistani. So that is the kind of prejudice you have against any population. It can be the mentally ill, it can be any population. And the basis of stigma is prejudice. That's all. And so I think this.
I think one question is directed towards Professor Varghese. So will the data collected from the survey help in formulating policies to improve mental health in general? Can ensuring good education for children with training in coping skills, social skills, etc., help in this regard?
Yeah, the answer to both questions is yes. It's well known that education and other positive mental health practices are very important to prevent mental disorders. So that's definitely important, and definitely looking at the numbers and looking at the kind of people who are suffering from mental illness and looking at the mental health system assessment will help the government to plan mental health services. So as a matter of fact, the National Mental Health Program has actually been launched in all the 600, 700 districts of India, though it may not be as good as it was in the initial districts. We are slowly getting there, and we are slowly getting money for training doctors, psychologists, social workers, nurses, and so on, so that every state in India can actually help for people who are actually suffering. I mean, it's all very well to say that mental disorders is just a figment of somebody's imagination, but talk to the people, the person who is actually suffering from depression or anxiety or some other phobia or OCD, or talk to the family members of people who have a serious mental disorder and ask them whether they are suffering and whether they want help. So if you use a very personalized, person-oriented approach and ask people whether they want help, whether they want access to care, whether they want access to treatment, that is something that you should ask them. It's all very nice for us to sit in our nice spaces and say that mental disorders don't exist and it's all a figment of people's imagination. So we should all talk to people who are suffering.
Yeah.
And ask them what they want.
Please intervene over here, because the whole definition of care has to be then sort of analyzed. What is the care towards? Is it towards the cure? Is it towards the relief from whatever the person is experiencing, or is it the entry of a person into the system, the mental health system, and no exit out of it, so that you are a permanent patient now and you're progressively disabled? Because that is where I'm coming from. I'm not saying that they don't require the care or that the doctors are not providing the care. Of course they are. Whatever they know, they are providing. And I'm not holding anybody responsible. But then we have to see where the care is leading, that's all. I'm not holding a finger at you at all.
I think we've had a long discussion of more than an hour, and I think we can just now wrap it up. And I would now like to thank all the speakers for making such important points during the course of this discussion. And in the end, I would just request the audiences to like, share, and subscribe to EPW. And thank you everyone for attending this webinar, and especially to our participants. And I would also like to thank Johan and Tia and Priyam, who were taking care of the technical aspect of the webinar, and also our edit members of the EPW team.
Thank you too.
Thank you very much, all of you.
Thank
Thank
you.
you to EPW. And we hope to see it on the
Yes,
YouTube
sir.
channel.
Yes, most definitely.
Thank you.
Thank you.
Bye-bye.